Oh, previously healthy, a previously healthy 6-year-old boy, a previously healthy 6-year-old boy is brought to the office. Is brought to the office because of 2-day history of right ear pain. He went swimming in the lake 3 days ago. On examination, the right ear canal appears normal with no pain on motion of the canal or tragus. The eardrum is red, bulging and immobile. Red, bulging and immobile. The left ear and the pharynx appear normal. The neck is supple. There is no lymphadenopathy. The remainder of the examination shows no abnormality. Which of the following is the most likely diagnosis?
Ready?
Ready?
Mhm. Okay, so it is acute otitis media. What is it? Yeah. Acute otitis media, an infection of the middle ear that classically occurs in children, causative agents include viral bacteria pathogen, commonly strep pneumo, moraxella catarrhalis, non-type of Haemophilus influenza. It presents with ear pain, often with fever, and right tympanic membrane with retrotympanic pulse and middle ear effusion, and conductive hearing loss. The middle ear is bounded externally by tympanic membrane and internally by the oval window. It is connected to the nasopharynx by eustachian auditory tube, which open into the posterior nasopharynx near the torus tubarius. Infection usually spreads to the middle ear by way of the eustachian tubes. First line therapy includes antibiotic treatment with amoxicillin with or without clavulanate, as well as symptomatic treatment. Recurrent episode may lead to inflammation of the adjacent mastoid bone and condition known as mastoiditis. Features of mastoiditis include those of otitis media plus opacification of the mastoid hair cells on CT scan and deviation of the ear. Children with recurrent episode of otitis media may benefit from surgical drainage with myringotomy and tympanostomy tube placement. It is not, where was that? This one. Otitis media with effusion, also termed serous otitis media, is suggested by the presence of a middle ear effusion in the absence of inflammatory signs of acute otitis, fever, tympanic membrane redness, and retrotympanic pulse. Serous fluid can accumulate within the middle ear because of eustachian tube dysfunction or obstruction, often in the setting of nasal mucosal inflammation from upper respiratory tract infection. Treatment is supportive as the condition is usually self-limited. Okay.
So the key here is red bulging tympanic membrane and
Yeah,
swimming.
yeah.
A 22-year-old, a 22-year-old girl with a recurrent cough and shortness of breath brought to the physician for a follow-up examination. She was born at term and weighed 3.2 kg. Pregnancy was uh, Pregnancy was uncomplicated. Recurrent episodes of wheezing with cough began after the age of 6 months, were successfully treated with combinations of oral antibiotic and beta-2 adrenergic agonists. She was admitted to the hospital for treatment of lobar. She was admitted to hospital for treatment of lobar pneumonia at age 9 and 12 and 16 months. She was treated for rectal prolapse 2 months ago. There is a family history of childhood onset asthma of varying severity persistent into adulthood. She is alert and asthmatic. She weighs 10.4 kg. Heart temperature is 37.3 degrees Celsius. Pulse is 115 per minute. Respiration 52 per minute. Examination shows mild subcostal and intercostal interaction. Diffuse diffuse inspiratory crackles hard with hyper diffuse inspiratory crackles are hard with hyperresonance to percussion. There is minimal clubbing of the nail bed. Annex of the chest shows generalized hyperinflation, bronchial thickening in the upper lobes, patchy atelectasis through the lungs. Which of the following is the most appropriate next step in the diagnosis? Clubbing.
Between A and C. Ready?
Yes.
Okay. So it is C, sweat colitis. Cystic fibrosis and autosomal. Okay. Autosomal recessive disorder caused by a defect in the CFTR gene leading to deficiency of chloride channel that secretes chloride in the lungs and GI and reabsorbs chloride in the sweat glands. The abnormal chloride transport causes decreased chloride and water secretion and increased water reabsorption, leading to abnormally viscous mucus. The thick mucus in the GI contributes to pancreatic insufficiency, steatorrhea, and malabsorption, leading to deficiency of fat-soluble vitamins. In the lungs, the disease manifests as recurrent pneumonia, especially with Staph aureus and Pseudomonas. Repeat antibiotic exposure increases the risk of colonization with resistant organisms. Obstruction and destruction of the airway leads to hypoxemia, air trapping, and bronchiectasis. Physical exam may show hypertrophic like the clubbing, cyanosis, wells, and bronchi, and hyperresonance to percussion of the chest. Yeah. Imaging findings include hyperinflation, bronchiectasis, um, bronchiectasis with peribronchial coughing, and diffuse non-specific inflammatory change. Diagnosis is made using the sweat chloride test. Where am I? Okay. Okay, I got it. And it's not a measurement of serum IgA concentration is useful in the diagnosis of APA, allergic bronchopulmonary aspergillosis, a hypersensitivity reaction caused by Aspergillus fumigatus, cystic fibrosis, and APA share the feature of bronchiectasis, yes. And having a cystic fibrosis is a risk factor for APA, yes. This patient presentation is more consistent with the diagnosis of cystic fibrosis. Hmm. Okay.
Okay. A 2.4 kg female newborn has tachypnea and intercostal retraction 25 minutes after delivery. At 32 weeks of gestation, a 23-year-old primary gravid woman. Membranes ruptured 1 hour prior to delivery. No meconium was found. Apgar score 7 and 7 in 1 to 5 minutes respectively. The mother is afebrile. Recurrent vaginal culture of the mother was negative for group B. The patient appears pink. Her temperature is 30.8 degrees Celsius. Pulse is 150 per minute. Respiration 70 per minute. Blood pressure 60 by 30 millimeter of mercury. Examination shows perioral cyanosis. Examination show perioral cyanosis, nasal flaring, granting intercostal retraction. Breath sounds are decreased bilaterally. Pulse oximetry on the room air. Pulse oximetry of the room air shows oxygen saturation 84%. Uh, after administration of 4 liter oxygen by mass, oxygen saturation becomes 91%. An extra of the chest showed diffuse bilateral haziness in the lung. Which of the following is the most likely diagnosis?
Emphysema. Ready?
Yes.
Good. Mm, and is highly membrane disease. Respiratory distress. Maybe I read from here. Respiratory distress syndrome of the newborn, also called highly membrane disease or neonatal NRDS, commonly occurs in premature infants and is caused by an inadequate production of pulmonary surfactant. Surfactant produced by type 2 pneumocyte functions to decrease surface tension of the alveolar membrane. Without enough surfactant, high surface tension leads to alveolar collapse. NRDS presents with tachypnea, hypoxia, accessory muscle use, and cyanosis. Tachypnea, hypoxia, and may lead to death. Chest X-ray commonly shows diffuse bilateral space and interstitial opacity. Biopsy is not required for diagnosis, but if performed at autopsy, it will show atelectasis with deposition of proteinaceous alveolar debris and hyaline material. Fetus risk for NRDS may be estimated by amniocentesis and calculation of the ratio of lecithin to sphingomyelin in the amniotic fluid. Surfactant is rich in phospholipids such as lecithin and sphingomyelin, and an increase in the lecithin to sphingomyelin ratio correlates with increasing fetal lung development. Surfactant reaches normal concentration of production in the third trimester, and infants who are born prior to 34-week gestation are at increased risk of NRDS. The treatment of NRDS is supportive. NRDS may also be both prevented and treated with steroids, which stimulate surfactant production. It is not between congenital emphysema, the rare pulmonary disorder caused by disrupted embryonic bronchopulmonary development and is characterized by air trapping and lung hyperinflation, which can be visualized on chest imaging. The severity of disease varies widely and may be asymptomatic until adulthood or present in newborn with respiratory distress. Okay, next.
What are the clues in this question?
Uh, the premature, the cyanosis, and I guess the chest diffuse bilateral blah 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 haziness.
Cyanosis,
Um,
hypoxia.
yeah,
X-ray finding is not typical, isn't it?
it is. Remember, we just saw a question that says that when it says haziness, that means atelectasis.
Yes, but it is not atelectasis, it is NRDS.
Yeah, but NRDS leads to
But
atelectasis.
NRDS has typical chest X-ray finding like diffuse ground glass opacity and AR bronchogram within it. We have read previously, isn't it?
Yeah, it's kind of the same thing. The haziness is that's what they call the
AR
what did you call it?
bronchogram.
No, the what did you say before? Diffused by
Diffuse ground glass appearance.
yeah. It's kind of what they are just calling it haziness. I just remember the haziness because we just read the question and it was saying that basically it was saying that haziness means atelectasis. And I know that NRDS causes atelectasis. So I was like, yeah, anyway. So just keep the word haziness as atelectasis in your mind. I think it will help.
Okay, next. Okay, look at the ECG and tell your finding.
Oh shoot. Nah, I cannot tell my friend here. Oh, I hate those ECG things. Um I think it's missing the T wave. Oh no. I don't know. I don't
What is the
know.
rate? There is no specific P wave, and a rate is very high. There is presence of P wave, but not that significantly.
Not that
I think that
significant.
it is SVT. Looks like SVT.
Oh,
Supraventricular tachycardia. Okay, I am reading the explanation.
okay.
Okay, a previously healthy 6 months old boy is brought to the emergency department One day history of decreased, progressively decreasing activity level and oral intake. His mother reports that he has had fewer wet diapers. He has had fewer wet diapers. He has not had vomiting or diarrhea. His temperature is 37 degrees Celsius, pulse 245 per minute, a pulse 245 per minute, and regular. Respiration is 32 shallow, blood pressure 60 by 30. He appears gray, poorly perfused. Pulse oximetry is not obtainable. He is lethargic but responsive to pain. Lungs are clear to auscultation. Abdominal examination show no abnormality. Abdominal administration of the supplemental oxygen is begun. She is placed on cardiorespiratory monitor. His ECG strip is shown. Which of the following is the most appropriate next step in the management?
Hmm. Don't know. Ready?
Yes,
Okay. So it what am I? Cardioversion. Supraventricular SVT commonly occurs in. So you knew it was SVT because not P wave and the thing is high. The pulse is high.
yes. If
Common,
the rate is like if the rate is more than 150 to 250 or more than 250, uh, it should be SVT.
more than 150 or more than 250?
More than 150, more
More
than
than one.
150 to 250. Like this is the range. More than 150 is SVT. You can easily predict.
SVT commonly occurs in children and infants, is characterized by paroxysmal episodes of rapid narrow complex tachycardia, infants and children. Infants often present with pallor, irritability, porphyritic cyanosis. SVT is often idiopathic and paroxysmal but may occur secondary to accessory pathways in some children.
And
May-
another thing I want to add, I know
Mhm,
you hate the box,
mhm.
but my duty is to
Yes.
uh, make you remember the boxes. Like if you find like if there is any tachyarrhythmia,
Mhm,
if any tachyarrhythmia, first thing you need to do like uh, assess the cardiac rhythm or airway management. You give oxygen, you give airway management, and then you should assess the cardiac rhythm. If it is sinus tachycardia, like P wave present and rate is more than 100 but less than 150, it means sinus tachycardia.
mhm,
Sinus P wave to be present and tachycardia rate should be more than 100 but less
mhm,
than 150. So
mhm,
it is sinus tachycardia. Then we should look for the cause of the sinus tachycardia. Hyperthyroidism is one of the cause of the sinus tachycardia. If no sinus tachycardia and patient is hemodynamically unstable, if patient is
mhm,
hemodynamically unstable,
mhm,
go for cardioversion, synchronized cardioversion. This patient, if we don't jump into the diagnosis also, this patient has, you can consider that this is not sinus tachycardia. So there is another type of like arrhythmia is present. Tachyarrhythmia is present, and this patient is not hemodynamically stable. So we can go for cardioversion like this case, like this case. And
mhm,
if hemodynamic instability is not present and QRS wave, if we look at the QRS complex, like onset of Q wave to end of the S, like QRS, you can this QRS complex is very narrow, like it
mhm,
is less than 3 small square. So QRS complex is narrow QRS complex.
Mm-hmm.
and the rhythm is regular, so you can think that this is SVT. If rhythm is not regular, then it may be atrial fibrillation. You got my point, what I'm talking about.
Mm-hmm. Mm-hmm.
So the two thing you can see, like you can see the red and you can see the QRS complex. If QRS complex is not wide, not wide and QRS complex, like very narrow QRS complex, then it may be SVT if regular, if rhythm is regular. They told us the rhythm is regular. If rhythm
Mm-hmm.
is irregular, then we can jump into atrial fibrillation or atrial flutter. And
Mm-hmm.
if QRS complex is wider, again we
Mm-hmm.
see the rhythm. If rhythm is regular, then it may be monomorphic VT. If the rhythm is not regular, maybe atrial fibrillation with aberrancy. Okay,
Mm-hmm.
I know
Okay.
a lot. Sorry, I know I have told a lot, but this flowchart sometimes
Yes.
help you in the exam.
I like how you summarized it. It sounds shorter than and I have to read the whole thing.
Okay,
SVT commonly occurs children. Okay, I already read that one. Infants often present with pallor, irritability, poor feeling, cyanosis. SVT is often idiopathic, and paroxysmal may occur secondary to Wolff Parkinson White syndrome. Diagnosis is made by electrocardiogram, although some children may require cardiac monitoring to capture a paroxysmal event. Um, AV nodal blockade with adenosine is the first line treatment for narrow complex SVT in a hemodynamically stable patient. In the AV node, binding of the adenosine receptor leads to reduced transmission of supraventricular action potential. If adenosine fails, additional AV nodal blockers or synchronized cardioversion may be attempted. Synchronized cardioversion is also the first line treatment in unstable SVT, as seen in this patient and suggested by the presence of hypotension and decreased endothelial damage. Decreased urine output, lethargy, motor skin. Children who are old enough may be trained to use vagal maneuvers to actually induce AV nodal blockade. Similar vagal maneuver may be attempted by placing an ice bag over the eyes and face for approximately 30 seconds. Okay, got it. Next.
okay. A 12-year-old girl is brought to the a 12-year-old girl is brought to the physician because of vaginal bleeding for 2 weeks. Pubertal development began at the age of 10 years. Her first menstrual period began 6 weeks ago and lasted for 10 days. She used to she used 10 to 12 sanitary pads daily. Her second menstrual period began 2 weeks and has not stopped. She has been using 12 pads daily until 2 days ago. Since then, she has used uh, six daily. Her temperature is 37, pulse 100, respiration 16, PP 90 by 95 by 60. Examination shows no other abnormalities. Hemoglobin 10, leukocyte count 10,000, platelet count 18, 1,80,000. PT 12, PTT is 45, high. Which of the following is most likely cause of this patient's finding?
Mm, 12, 13. Ovulatory menstrual cycles.
Okay.
Factor 11. Mm,
Ready?
yeah. Yep. Okay. is, did I pass it through here? Oh, it's von Willebrand disease. Now see that one coming. The most likely diagnosis in this patient with menorrhagia leading to anemia and isolated increased PTT is von Willebrand disease. Plate table tennis. Okay. A common coagulopathy affecting platelet qualitative function. Von Willebrand disease results from impairment of the amount in the amount of function of von Willebrand protein multimeral plasma protein that binds to platelet to that binds platelet to subendothelial collagen. The deficiency results in impaired hemostasis, generally involving mucosal and epithelial location due to deficiency of platelet adhesion. With von Willebrand can be genetic, autosomal dominant, or acquired. Since von Willebrand multimer also acts as a serum transporter for cofactor, coagulation factor 8, coagulation factor 8 concentrations may be decreased. Okay, leading to the increase in PTT without affecting PT. Patients often present with menorrhagia, recurrent nosebleed, easy bruising, petechiae, GI, and gingival bleeding. Unless blood loss is substantial, lab studies will otherwise be normal. Mild or with brain disease is generally asymptomatic, although moderate or severe deficiency can result in transfusion dependent anemia and bathing hemorrhage and shock. Treatment in addition to supportive care with bleeding control and transfusion may involve administration of desmopressin, which promote the release of 1 billion stored in endothelial cells. It is not an ovulatory menstrual cycle can cause menorrhagia caused by prolonged proliferation of the endometrial lining. However, an ovulatory menstrual cycles are generally associated with irregular time intervals between periods. This patient has had normal cycle length and recurrence, making an ovulatory cycles an unlikely cause of menorrhagia. They will also not describe the increase in this patient PTT. Makes sense. Factor what is it? 11 deficiency is an uncommon coagulopathy caused by genetic or acquired quantitative or qualitative compromise of factor 11. It may result in bleeding, such as seen in this patient. However, bleeding associated with factor deficiency more commonly occurs early in life and is visceral as opposed to mucosal location. Makes sense. Factor 11, 12, 13 deficiency is a rare coagulopathy that leads to spontaneous bleeding, including hematosis and intracranial hemorrhage. While it can cause menorrhagia, it more commonly present early in life. Factor 13 deficiency will also cause a prolonged PT and PTT. PT and P, yeah, will cause PT and PTT. Okay.
Okay, can you tell me the PT, PTT, platelet count, and bleeding time in case of von Willebrand disease and uremic platelet dysfunction?
The okay, you said for one believer you want the bleeding time and what? PT and PTT?
PT, PTT, platelet count, and bleeding time. These four things.
PT,
Like
PTT,
how
platelet count. Okay.
if
So
okay, hmm,
mhm. So bleeding time for von Willebrand, I'm guessing it will be high.
okay,
Platelet count will be normal. And then you say PT plate table will be normal and PTT will be high.
and uremic platelet dysfunction
Uremic platelet. Bleeding time will be high, I'm guessing. Platelet count will be normal because it's a problem with the dysfunction, not the count. Yeah, will be normal. And PT and PTT, I think they'll be normal. Not sure.
would be normal.
Will be normal. Okay. And bleeding, sorry, platelet count will be what? Am I right?
Platelet
Is it
count is yes, platelet count is
normal?
normal. From the
Okay.
in here the problem in the bleeding time. It is one of the bleeding disorder.
Okay.
So bleeding time is high. Like bleeding time is high in von Willebrand disease, in DIC,
Mm-hmm.
in uremic platelet dysfunction, and also, can you tell me the ITP, idiopathic immune thrombocytopenia? This is actually tough. I think so.
Oh, you want the same thing, bleeding time, platelet, same
Yes.
thing? Okay. Immune thrombocytopenia. Bleeding time, I'm guessing, will be increased because there's an issue with platelets. Platelet count will be decreased because there's issue with platelets. And PT and PTT, would they be normal?
Yes, it is normal.
Okay.
Okay. Okay. Next,
Mm-hmm.
I am adding some things which is required for this question.
No,
Okay.
I like it. Please squeeze me.
A 2-week-old newborn is brought for a well child examination. He was born 38 weeks he was born at 8 weeks of gestation, 27-year-old primary gravid woman following uncomplicated pregnancy and delivery. He weighed 2.2 kg. He is at 5th percentile for length and had head circumference. He is at 5th percentile for length and weight and head circumference. Examination shows short palpable fissures, maxillary hypoplasia, micropnathia, thin upper lip. The lungs are clear to auscultation. A grade 1 by 6 systolic murmur is heard at the left sternal border with radiation to the axilla and the back. Femoral pulses are normal. A neurologic examination shows mild hypotonia. Which of the following is the most likely diagnosis? Is it alcohol?
That's what I wanted to go to, but thin upper lip. But they didn't say anything about the smooth filter. Usually alcohol, they will bring the smooth filter. And I don't know if alcohol has the small maxillary, blah, blah, blah. I don't know. But it looks like alcohol though. Okay, let's see. Ready?
Yes.
Yep, you're right. It's alcohol. Alcohol is a proven teratogen, as alcohol use during pregnancy leads to reversible fetal neurologic effects and physical malformation in a cluster of things called fetal alcohol syndrome. Due to disruption of cell migration during development, fetal alcohol syndrome presents with physical abnormalities such as microcephaly, so small head, facial abnormalities, small palpable fissures, eyes, maxillary hypoplasia, so small, yeah, thin vermilion border, cleft lip palate, smooth philtrum, limb deformities, and congenital heart disease. Mhm. Fetal alcohol syndrome is the leading cause of intellectual disability in the US. Muscular abnormalities, gross motor delays, hypotonia, tremorlessness are also common. Patients with fetal alcohol syndrome may demonstrate abnormal development like cervical spine fusion and delayed bone growth. It is not D, E, and F. Let me see. It's not the fragile X-linked dominant cause of inherited intellectual disability that presents with intellectual development disorder, an elongated face with prominent jaw, high arch palate, large ears, hyperextensible joint, post-pubertal macrokidism. This patient's jaw size is small and he does not demonstrate hyperextensible joint. Okay. It's not seminiferous to dysgenesis. Klinefelter caused by XY karyotype, which causes dysgenesis of the seminiferous tubule. And testicular atrophy leading to decreased spermatogenesis. Dysmorphic body features includes eunuchoid body shape, I'm guessing like female body shape, long extremities, and gynecomastia will be observed. This patient does not demonstrate dysmorphic features consistent with that. Trisomy 13 Patau presents with intellectual development disorder and characteristic physical features including cleft lip palate, holoprosencephaly, microphthalmia, small eye, cutis aplasia, forgot what it was, all the things in the head, feet with prominent calcaneus and convexly rounded soles, polydactyly. This patient does not demonstrate gross neurologic abnormalities consistent with that. Okay, next.
Okay. A 15-year-old girl is brought to the physician because she has not begun to crawl or walk. She has been exclusively breastfed since birth. She is at 50 percentile for length, 85 percentile for weight. Her language and social skills are appropriate for age. Examination shows no abnormality except for widening. Examination shows no abnormality except for widening of the wrist. Which of the following serum findings is most likely to be increased?
Mm, 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 mm. Calcium. Oh, don't know. Maybe.
Yes.
Okay. So its alphos activity will be increased. Alphos is an enzyme present in the bile ductures and the bone. It plays a role in bone mineralization by osteoblasts, though the exact mechanism is unknown. Vitamin D plays a role in serum calcium and phosphate homeostasis by promoting intestinal absorption of calcium and phosphate, increasing bone mineralization and at low concentrations, and increasing bone resorption at high concentrations. PTH also has a role in calcium and phosphate regulation by stimulating osteoclast bone resorption and calcium reabsorption and phosphate excretion. Vitamin D deficiency can be caused by malabsorption in the intestinal tract, malnutrition, and insufficient dietary intake and decreased sun exposure. Decreased concentration of vitamin D results in decreased intestinal calcium absorption and hypocalcemia. Sensed by the PTH parathyroid gland via calcium sensing receptors, leading to an increase in PTH secretion to normalize serum calcium concentration. Mm. Increased PTH results in increased osteoclast activity, intestinal calcium absorption, and kidney tubular absorption of calcium and excretion of phosphorus. Increased osteoclast activity leads to increased bone turnover, which releases calcium and alphos into the bloodstream. Okay. This leads to rickets in children, characterized by frontal bossing, bone pain and deformities such as bowing of the leg, widening of the zones of mineralization on radiograph, caused by unmineralized osteoid, hypoplastic teeth, bulging of the costochondral junctions, and growth delay. In infants such as this patient, bone pain may manifest as refusal or inability to crawl or walk. Because of the risk of vitamin deficiency, breastfed infants are recommended to receive oral vitamin D supplementation. Okay, so it's not, what was I? C or E. Calcium concentration is slightly normal or decreased because this patient intestinal calcium absorption is low. Hypercalcemia and bone turnover are features of primary hyperparathyroidism. Manifestation of hypercalcemia includes nephrolithiasis, abdominal pain, constipation, pancreatitis. Okay. Phosphorus concentration will be normal or low in this patient due to decreased vitamin D and increased PTH. Hyperphosphatemia is associated with hypoparathyroidism. Low PTH leads to impaired kidney phosphorus excretion. Serum phosphorus is also increased in secondary hyperparathyroidism due to chronic kidney disease, as impaired phosphorus excretion results in binding of serum calcium by phosphate and increased PTH, which leads to osteodystrophy. Okay. Okay.
Next.
So is calcium and okay. Got it.
A 6-year-old boy is a 6-year-old boy is brought to the clinic. A 6-year-old boy is brought to the clinic by his mother because of intermittent bed waiting. Because of intermittent bed waiting. He was toilet trained at age 4 years but has never remained dry through the night and typically wets the bed 3 to 4 times weekly. He found he does not wet himself during the day. He has not had pain with urination, urinary urgency, hesitancy, dribbling. Urine stream is normal. His mother says that he does not snore, but he is heavy sleeper. He has not had fever, diarrhea, constipation. He recently started first grade and has not yet made any friends. Growth and development are otherwise appropriate for age. Vital signs are within normal limit. Abdomen is soft and non-tender. The penis is circumscribed. The testis is descended. pH is 7. Specific gravity 1.020. Glucose, protein, blood, ketone, nitrate, shop, all negative. Which of the following is the most likely explanation of this patient's anabasis? Ready?
Mhm. Maturation delay. Primary enuresis refer to episodic urinary incontinence occurring in children older than 5 years old who have never remained dry throughout the night. The pathogenesis of primary enuresis most commonly involves a delay in maturation, though may alternatively be related to a small function of bladder capacity or genetic factors. The episodes commonly lead to adjustment problems and low self-esteem, along with avoiding diarrhea. Patients with nocturnal enuresis should undergo throughout history physical exam and analysis to rule out medical causes of enuresis like bladder dysfunction or UTI. Many patients with primary enuresis spontaneously improve, though multinational therapy may hasten improvement. In patients with persistent enuresis or enuresis associated with emotional problems, management with enuresis alarms of desmopressin is indicated. It is not primary sleep disorders is characterized by insomnia and dysregulated sleep, not heavy sleeping. Primary enuresis is not characterized as a sleep disorder. It's not adjustment disorder refers to the onset of dysproportionate distress within 3 months of memory. Adjustment disorder are typically associated with anxiety, depression, behavioral symptoms without yeah. Though the patient is having difficulty making friends, he does not show depressive or anxiety symptoms. Okay, next.
And an 18-year-old woman comes to the physician because she has never had a menstrual period. He takes no medications. She is uh, she is 163 centimeter tall and weight is 60 kg. BMI is 23 kg per meter square. Her temperature is 37. Pulse is 80 per minute. Respiration is 20 per minute. Blood pressure is 110/60. Breast development. Breast development is sexual maturity rating stage 1. Pubic hair development is sexual maturity rating is stage 3. Pelvic examination shows normal vagina. Pelvic examination shows normal vagina and a small uterus. Our serum FSH hormone is 92 high. Which of the following is the most appropriate next step in the diagnosis? FSH is high, isn't it?
Yes.
Mm,
Ready?
Wait 1 second. Okay.
So it is karyotype analysis. Gonadal dysgenesis Turner syndrome is a cause of primary amenorrhea, which is secondary to ovarian dysgenesis in the setting of 45XO genotype. Other signs of gonadal dysgenesis include short-stature cystic hygroma, web neck, swelling of the hand and feet, coarctation of the aorta, bicuspid aortic valve, horseshoe kidneys, infertility. Additionally, because of decreased estrogen concentrations, patients fail to develop secondary sexual characteristics such as breast and demonstrates underdeveloped uterus. Vital signs will be normal, and diagnosis is made to karyotype analysis. Other lab studies that may aid in diagnosis are increased concentration of LH and FSH caused by the lack of negative renal. Gonadal dysgenesis for management in adolescents commonly involves monitoring for cardiac complications, growth hormone replacement, and estrogen replacement to promote increased stature and development of sexual characteristics. Okay, next.
Okay. A 3-month-old female, a 3-month-old female infant born at 34 weeks of gestation, admitted to the hospital in January because of 3-day history of copious rhinorrhea, fever, poor feeding, and periods of tachypnea. Her 3-year-old brother was diagnosed with upper respiratory tract infection 5 days ago. Her temperature is 38, respiration is 65 per minute, blood pressure is 60 by 40. Pulse oximetry on room air shows oxygen saturation 92%. Physical examination shows intercostal interaction. Wheezes are heard bilaterally. A chest X-ray show hyperinflation and peribronchial coughing. Hyperinflation and peribronchial thickening. Which of the following is the most likely pathogen?
Hyperinflation. She's 3 months. This is in January.
Her brother had an infection too.
Oh, yeah. Okay, so I'm in between influenza, RSV, strep pneumo, peribronchial thickening. Probably not strep pneumo. Her brother is 3 years old. Maybe influenza. I don't know. Ready?
Yes.
January doesn't fall on the influenza thingy. So it's RSV. Bronchiolitis. Here. Bronchiolitis is a common cause of lower respiratory tract infection in children under age 2. It is typically caused by viral infection like RSV. It presents with viral prodrome like fever, nasal congestion, and rhinorrhea, followed by cough, shortness of breath, and lethargy as inflammation progresses to the lower airway. Auscultation may disclose wheezes and crackle. Severe disease is marked by presence of increased respiratory effort. Mm, okay. May increase tachypnea, accessory muscle use, intercostal retraction, nasal flaring, grunting, hypoxemia, and apnea. Patients presenting with severe disease should be hospitalized and immediately started on respiratory support with administration of oxygen, suctioning, and consideration of advanced airway management if respiratory failure is imminent. It's not, where was I? Influenza is common cause of viral pneumonia during the winter months. Bronchiolitis is more common caused by RSV. It's not staph aureus is more common associated with skin and soft tissue infection. Septic arthritis and enteritis. It can cause pneumonia, though thus so more frequently in post-viral superinfectious or in immunocompromised. It also colonizes the lung in patients with cystic fibrosis. It will be unlikely pathogen to infect an otherwise healthy child. And it's not. Strep pneumo is a common bacterial cause of pneumonia, but patients tend to present with focal lung findings indicating lobar pneumonia as well as lobar consolidation on X-ray. Diffuse wheezing on examination and peribronchial thickening on chest X-ray are more consistent with bronchiolitis. Okay.
Next,
Mhm.
a previously healthy 4-year-old boy is brought to the office because of 3-day history of easy bruising that began on extremities but now includes the trunk. There is no history of trauma. His parents say that he is active. His temperature, his his parents say that he is active. His temperature is 37, pulse is 100, respiration 16. Examination shows scattered petechiae and examination shows scattered petechiae and multiple ecchymosis in various stages of healing over the trunk and the extremity. They are more pronounced on the extremity. Lab studies show hemoglobin 12, leukocyte count, hemoglobin 12, leukocyte count 6,000, platelet count only 1,000, PT 12, PTT is 34. Which of the following is the most likely cause of this patient's condition?
Mm,
Is it
mm,
ITP?
Why?
Sorry,
But, why? PT and PTT are both are normal.
normal. In ITP,
Abnormal
PT is normal, platelet count is low, bleeding time is high.
platelet function. Platelet function. Uh, decrease platelet production. Decrease platelet production. Okay. Disseminated intravascular. Increase platelet destruction. But he has, I don't know. I definitely have to read all that. Ready?
Yes,
So it is increased platelet destruction. Damn it. ITP, you're right, is caused by antiplatelet antibodies that bind platelets, leading to opsonization and destruction. Platelet destruction occurs when MAX within the spleen phagocytose the platelet antibody complex, resulting in thrombocytopenia. ITP is diagnosed in the setting of low platelet count and absence of other explanatory causes of thrombocytopenia. Bone marrow biopsy with classic show an increased number of megakaryocytes indicating adequate platelet production, but increased peripheral destruction of platelets. It classically presents with petechia purpura and prolonged bleeding time on lab,
mm,
although bleeding time is rarely measured. Whatever. So severe ITP may lead to uncontrolled hemorrhage. Acute ITP is often seen in pediatric patients, may follow an infection, generally self-limited and is managed conservatively in the absence of yeah, life-threatening bleeds. It is not okay. Abnormal platelet function may be seen in genetic conditions such as Gassman thrombocytopenia, in which patient had defect in the GP2B3A protein, preventing blood platelet aggregation and formation of platelet clot. It's not true. Decreased platelet production may be a result of conditions such as aplastic anemia. This condition typically presents with anemia, thrombocytopenia, and leukopenia. It may be associated with parvo B19 infection in children, especially in those with sickle cell anemia. It's not DIC is a systemic disorder characterized by widespread activation of clotting cascade, resulting in microthrombi formation, thrombocytopenia, bleeding complications due to consumption of platelets and clotting factor. It can be provoked by trauma, sepsis, malignancy, pancreatitis, exposure to toxins, and other things. Lab studies show thrombocytopenia, prolonged PT and PTT, decreased fibrinogen concentration, decreased platelet count, and increased D-dimer fibrillation. Okay, so here I guess the PT and PTT were normal.
Normal.
Okay, that was confusing. Okay. Okay. I was confused by this. I don't know why they give those
Which
control
one?
thingies. The control. Because you see here, if you look at the control, it seems like the
Slightly
PT is
high,
high.
not that high.
Really high. But if you look at the lab values,
Yes.
they're actually both normal.
Yes, that's why I don't look
Yeah.
at this. I try to remember those previous lab values. But in here, there is another problem in this question.
Mm-hmm.
According to pathophysiology of the
Mm-hmm.
ITP,
Mm-hmm.
we know that ITP is a diagnosis of exclusion, isn't it?
Mm-hmm.
Uh, if it is ITP is immune mediated, we know that, and the mechanism is increased platelet destruction like that.
Mm-hmm.
But there are some other mechanisms too, like decreased platelet count and platelet sequestration. Like decreased platelet production usually happens in the bone marrow disorder, like if there is any infection, or if there is any neoplasm, or if there is any aplastic anemia, then uh, those ITP can happen due to decreased platelet production. You got my point. This one is immune mediated. That's why it is increased platelet destruction.
Okay.
Okay,
Okay.
don't make it complex. Okay, next.
Okay.
A 10-year-old girl is brought to the physician. A 10-year-old girl is brought to the physician because of 6 months history of increased facial hair growth and facial acne. She is at 50 percentile for uh, she is at 50 percentile for height and weight. Her temperature is 37 degrees Celsius. Pulse is 64 per minute. Respiration is 12 per minute. Blood pressure is 110 by 60. Examination show mild clitoral enlargement and early male pubic hair pattern. Mild clitoral enlargement, early male pubic hair pattern. Lab study shows a lab study show increased serum testosterone concentration 0.2 nanogram, sorry, 0.2 nanomole per liter. 0.2, okay, normal. The hydroepiandrosterone sulfate is 9 high dehydro, and urine 17 keto steroid excretion is 20 milligram per 24 hour. Pelvic ultrasonograph show no abnormality. Which of the following is the most likely diagnosis?
Ready?
Yes.
So it's what is adrenal adenoma. The adrenal cortex is composed of three zones, including zona glomerulosa, producing aldosterone, zona fasciculata, cortisol, and zona reticularis, dihydroepiandrosterone sulfate. In the zona reticularis, 17-hydroxypregnenolone is converted to dihydroepiandrosterone sulfate by 17-alpha-hydroxylase. Patient will present with virilization of the female genitalia, hirsutism, and elevation of dihydroepiandrosterone sulfate and 17-keto excretion should be evaluated for the development of adrenal adenoma. And these patients will have normal testosterone concentrations as well as normal pelvic ultrasound. Okay.
So
Mhm.
we need to see the like dehydrated level. As it is high, it came from zona reticularis, so that's why it is adrenal adenoma.
The key is the dihydroepiandrosterone sulfate. Every time you see the DHA sulfate, stop reading the question. It's something to do with the adrenal adenoma. It's the only one that produces the DHA sulfate. The ovarian produces just DHA. Once you see the sulfate, that means it comes from the adrenal gland.
Okay. A two-day old male newborn is evaluated in the hospital for hydronephrosis, first seen on prenatal ultrasonography at 28 weeks of gestation. He was born at term following spontaneous vaginal delivery. He feels well. Feeds well from a bottle. He feeds well from a bottle. Vital signs are within normal limits. He voids during examination. Urine output is normal, but urine flow is poor with dribbling of the urine from the penis. Postnatal ultrasonography show bilateral hydronephrosis and hydroureter and a thick walled bladder. Which of the following is the most likely diagnosis?
Ready?
Wait 1 minute.
Mhm.
Okay.
So it is posterior urethral valve. Congenital urinary tract abnormalities include, but are not limited to unilateral renal agenesis, fused kidneys, ureteral strictures and stenosis, duplex collecting system, posterior urethral valve, bladder agenesis, bladder extrophy, hypoepispadias, and urethral strictures. Posterior urethral valves have formed from an abnormal remnant of the mesonephric walking duct that result in urinary tract obstruction. This is often diagnosed on prenatal ultrasound showing bladder distension, hydronephrosis, hydrangeals, and fetus that is small for gestational age. Some of the features were notable in this patient case. In this patient, an abnormal voiding pattern plus postnatal ultrasound suggests posterior urethral valve as a cause of urinary obstruction. Complications include rupture of the calyx around the kidneys, bladder rupture, and kidney failure. Definitive diagnosis of posterior urethral valve is made with voiding cystourethrogram showing dilation, elongation, and tapering of the urethra. Treatment is with endoscopic valve ablation.
So voiding cystourethrogram for posterior urethral valves. But if there is any straddle injury like urethral injury, we will do retrograde urethroplasty.
If there is blood in the meatus, then you do the retrograde.
If
If
blood in
any
the meatus, urethral meatus, then retrograde
urethra,
urethroplasty.
yes. And if there is anything to do with the bladder, then you do the voiding whatever cysto thingy. Yes, no,
Okay.
okay.
A previously healthy a previously healthy 15-month-old boy is brought to the physician in late winter by his mother because of persistent vomiting, followed by fever and the diarrhea. His symptoms began 2 days ago, and a large family. His symptoms began 2 days ago after a large family gathering. His mother tried to give apple juice, but he vomited the juice after drinking only 4 ounces. The patient is crying and appears alert. Temperature is 39, pulse is 120 per minute, respiration 36 per minute, blood pressure 88 by 56, capillary refill time is normal. Examination showed tear production, slightly dry mucous membrane. Tear production, slightly dry mucous membrane. The abdomen is non-tender. The abdomen is non-tender. Bowel sounds are hyperactive. Test of the stool for occult blood is negative. Which of the following is the most appropriate treatment for this patient?
Hmm. I was going to say oral hydration, but he is having vomiting. So, I don't know. Do we stop the diarrhea? Not really. That was bismuth subsalicylate. I don't remember what was that. Beta prochlorperazine. Mm, I guess I did extras. I don't think it's that, but I feel like it's the oral bismuth thingy. Okay, ready?
Yes.
Okay. Eight. Oh, what is it? Oh, oral hydration. Even if he's throwing up, acute onset fever, vomiting, diarrhea is consistent with gastroenteritis. Though this is typically self-limited in children, with children with gastroenteritis are increased risk for volume depletion in comparison to adults. And these patients should be treated initially with oral hydration solution. Clinical signs of volume depletion like tachycardia, tachypnea, hypotension, dry mucous membrane, poor skin, tuber, blah, blah, blah. Children may present with irritability or lethargy. Lab evaluation may show perturbations in serum sodium, bicarb, and potassium concentration. Volume depletion secondary to diarrhea is usually accompanied by a significant stool loss of bicarb, which in combination with hypoperfusion of end organs may result in metabolic acidosis. Urinalysis shows aciduria and high urine-specific gravity. Treatment includes replacement of fluids and electrolytes. It is not oral bismuth salicylate. It is a non-antibiotic treatment option for adults with acute gastroenteritis, but should be avoided in children and pregnant women because of the risk of salicylate toxicity. Okay. Oral loperamide and other antidiarrheal are generally not recommended for treatment in acute gastroenteritis in children. The condition is usually self-limiting. There is little known effect of this agent, however. Rectal prochlorperazine is an antipsychotic and effective antiemetic, typically reserved for severe refractory nausea and vomiting. Chemotherapy-induced nausea and vomiting, okay, and intractable migraine in children. Okay. IV 5% extract in water or any isotonic intravenous fluid is indicated for severe volume depletion in children, though unfeasible and tolerated oral rehydration is preferred. Okay. Severe volume depletion is characterized by delayed capillary refill time, cold and motile extremities, lethargy, and hypovolemic shock. Okay, next.
A four
Oh my,
month, yes, a four
oh,
month, I was not sleeping.
okay.
A 4-month-old girl is brought to the physician for a well child examination in October. Pregnancy and delivery were Pregnancy and delivery were uncomplicated. Immunizations are up to date. Growth and development are appropriate for age. Vital signs are within normal limit. Examination shows no abnormality. Imaging against which of the following is the most appropriate in this time?
The immunizations are up to date. Mm. Ready?
Yes,
Oh, so it's rotavirus. Rotavirus is a double-stranded RNA virus that causes infectious diarrhea in children. Rotavirus infection is the most common cause of diarrhea illness in children in the world and is commonly acquired during the first several years of life. The virus is transmitted fecal orally and is highly contagious. Viral shedding in the stool can occur prior to development of symptoms and potentially allow asymptomatic patients to become vectors for disease. The diarrhea caused by rotavirus is watery, profuse, and often foul smelling and is typically not bloody. While most cases are self resolving, severe infection may produce dehydration, which may be life threatening, particularly in low resource whatever. Rotavirus vaccine is available in a variety of live attenuated formulations. It's 4 months. Okay, and it's recommended for all children. The vaccine is given in 2 or 3 doses series beginning at age 2 and 6 months. It is not influenza vaccine is recommended for prevention of influenza. It begins at 6 months. Okay. Chickenpox caused by varicella virus. Vaccine against varicella is administered in 2 doses starting at 12 months. Okay, because it's live. Measles, mumps begins at 1 year old, so 12 months because it's live. Shingles, that's in old people. Okay, got it.
okay, next. A 15-year-old boy is brought to the emergency department 1 hour after the onset of the nausea and vomiting. Examination: nausea, vomiting, weakness, and headache that began during practice of cross-country meet. On arrival, he is mildly disoriented. 1 week ago, he had a viral gastroenteritis, missed 4 days of practice. He turned to practice 3 days ago. Today, the outside temperature has been near 90 degrees Fahrenheit. His coach reports that he observed him drinking large amount of water before and during practice. The patient reports that he skipped lunch today. He is at 25% for height and the weight. His temperature is 37 degrees Celsius. Pulse is 100 per minute. Blood pressure is 100 by 75. Examinations show edema of the hands and the feet. Which of the following is the most likely explanation of this patient's symptoms?
Is it heat stroke or is it hypoglycemia? Mildly disoriented.
Examination show edema of the hands and the feet.
Edema of the hands and the
Heat
feet.
stroke does not cause the edema,
Okay.
isn't it?
I don't think so, no. Okay.
Why he is swollen?
I don't know, but the only thing that makes, I don't know,
And drinking large amount of water before, is it hyponatremia?
hyponatremia. Yeah, maybe. I don't know if it causes edema, but yeah, no, it's hyponatremia. Maybe, maybe, yeah,
Okay, what?
maybe.
Okay,
It's hyponatremia, yeah. This patient with altered mental status and edema in the setting of recent electrolyte depletion from gastroenteritis followed by large volume water intake likely has hyponatremia. Excessive fluid intake can lead to delusional hyponatremia, likely worsened by the now resolved volume depletion from the patient's previous illness. An abrupt decrease in serum osmolality leads to transcellular shifting of fluid by osmosis, with neuronal swelling in the central nervous system, which can lead to findings ranging from mild confusion to disorientation to brain emission. Treatment for hypervolemia, depends on the severity of symptoms and specific cause, heart failure, kidney or liver failure. If significant altered mental status is present, treatment involves administration of hypertonic saline to correct osmolar shift and address severe neurologic symptoms and prevent seizure. Management for mild hypervolemic hyponatremia involves water restriction and diuretics. It is not all the other ones. Dehydration can lead to headache, weakness, nausea. If severe dehydration can lead to hypotension and subsequent cerebral hypoperfusion. Hypotension and hypoperfusion may lead to disorientation. This patient history of large volume water intake along with altered mental status. In the center, a normal blood pressure make dehydration. What is with blood pressure? Yeah, I guess it's normal. Heat exhaustion is characterized by exercise intolerance, increased body temperature, generalized weakness, and muscle cramps, and the absence of neurologic findings. Heat stroke occurs in the setting of high environmental temperature and high humidity. Excessive heat exposure and increased core body temperature leads to cardiovascular and neurologic dysfunction. It's characterized by hyperthermia, altered status, and neurologic deficits and variable physical signs and symptoms depending on severity. This patient history of recent electrolyte depletion followed by large volume of water intake makes hyponatremia more likely. Hypoglycemia can cause confusion, altered status, and weakness. The patient will be at risk for hypoglycemia caused by exercising after not eating since breakfast. However, healthy individuals are typically able to maintain a stable serum glucose concentration because of hepatic glycogenolysis during periods of exercise and fasting. Mhm. Okay, next.
okay. An 18-month-old boy is brought to the physician because of poor linear growth. There is no history of vomiting, diarrhea. His blood pressure is 90 by 60. Sodium is 138, chloride is 112, potassium is low 3.1, bicarbonate is 16, urine pH is 7.6. pH is 7.28, PCO2 is 26, and PO2 is 98. So metabolic acidosis. Which of the following is the most likely cause of this patient's hypokalemia? The 1928 iron metabolic acidosis. Iron, no, no, RTA. Uh, it is normal and metabolic acidosis, isn't it?
Don't know. I didn't calculate the anion gap.
If
So
you
it
calculate it, then it would be easy.
renal artery stenosis. So it's normal. Oh, what was it again? Sodium minus chloride plus glycol. It will be 112 plus 16. 112 plus 16, 128, 138 minus 128. So it's non-ion gap. Probably this one then.
Okay.
This renal tubular acidosis. Hmm.
Normal iron gap 1 and 2 is for hypokalemia and 4 is hyperkalemia, isn't it?
Yeah. RTA results in hyperchloremic non-ion gap metabolic acidosis from dysregulation of kidney tubules. There are three types of RTA varying in cause and pathophysics, but all result in non-ion gap metabolic acidosis. This patient shows a low bicarb concentration with normal anion gap consistent with non-ion gap metabolic acidosis. This type 1 is caused by defect in kidney secretion of hydrogen, which result in the lack of generation of bicarb, ultimately leading to metabolic acidosis. It's characterized by high urine pH. The most common cause of type 1 RTA is analgesic nephropathy, congenital obstructive urinary tract abnormalities, drugs, autoimmune disease, rheumatoid arthritis like Sjogren, and yeah. This patient arterial blood gas shows respiratory compensation done incomplete. RTA is associated with kidney potassium wasting and hypokalemia. Wait, what did he have here? Oh, hypokalemia, sorry. It is not, I was confused between Addison disease or primary adrenal insufficiency, commonly due to autoimmune destruction or tuberculosis. It presents with hypotension, hyperkalemia, and here we have hypokalemia. Okay. Hyperkalemia, metabolic acidosis, and skin hyperpigmentation secondary to deficiency. And it's not, what was that? Pseudohypoaldosteronism is characterized by problems with sodium regulation leading to hyponatremia, hyperkalemia, and hyperchloremic metabolic acidosis. Renal artery stenosis can lead to CKD, which presents with increased creatinine, electrolyte, and acid-base derangement, hypertension. Okay, okay.
Next. A 3-day-old girl undergoes a 3-day-old girl undergoes evolution prior to discharge from the hospital. She was born at 39 weeks of gestation following an uncomplicated pregnancy cesarean delivery. For cephalopelvic disproportionate weight is 3.2 kg. Examination of the birth showed an abnormality. She is exclusively breastfed. She is alert and active. Her temperature is 37.1, pulse is 104 per minute, respiration 36 per minute. Pulse oximetry on room air shows oxygen saturation 99%. A new grade 2 by 6 systolic murmur is heard on the pulmonic area with radiation to the lungs and is loudest at the right axilla. Peripheral pulses are normal. Which of the following is the most likely diagnosis? Ready?
Systolic murmur. As long as that makes sense. But wait, can also be ASD. But ASD is not systolic. Hmm. Pulmonary stenosis. Oh, why do I feel like it's ASD? Okay, ready. Oh, no, that was easy. The most likely diagnosis is pulmonary stenosis, often diagnosed early in life and in female patients more than male. Pulmonary stenosis is typically congenital and benign, or it may be associated with other congenital cardiac syndromes. Um, the blockage may occur at the level of the pulmonic valve as a result of fusion of the commissures or other defects of the leaflets. Subvalvular caused by narrowing of the right ventricular outflow tract. Also, paravalvular, also called peripheral pulmonic stenosis, caused by narrowing or impingement of the pulmonary artery. Mm, a physical exam findings depend on the severity of the stenosis. Most patients will have a systolic ejection murmur with radiation to the back. Some may have associated ejection click, split S2 or parasternal heave. Most patients are asymptomatic, though complications can occur if the condition persists in adulthood. Surgical revision and balloon valvotomy have excellent prognosis. It's not ASD. What is ASD? ASD is a common congenital malformation of the interatrial septum resulting in left to right shunt. Examination typically shows a fixed widely split S2 caused by increased blood flow to the pulmonic valve. Severe defects can result in pulmonary hypertension and Heisenmenger syndrome with reversal to, yeah. Okay. Okay, next.
Okay. What is this? A previously healthy 10-month-old boy is brought to the emergency department by his mother because of 10-year history of bloody mucoid stool. He also had vomited 3 times. He also had vomited 3 times during that time. Her mother says that he cries and draws his legs during the episodes of vomiting. Between episodes, he appears uncomfortable. He is playful. He is not distressed. Temperature is 37.1 degrees Celsius. Pulse is 110 per minute. Respiration 24 per minute. Blood pressure 96 by 58. Abdominal examination shows mild distension. Abdominal examination shows mild distension. A 4 by 6, a 4 centimeter tender elongated mass is palpated in the right upper quadrant. There is no hepatosplenomegaly. Rectal examination shows bloody mucoid stool in the rectal wall, mucoid stool in the rectal wall, results of a contrast in immersion. Which of the following is the most likely explanation of this finding?
He's vomiting and he has bloody stool. Hmm. Ready?
Okay, is it intersection?
That's what I'm between that and my rotation volvulus, but I guess it's interoception. I'm thinking. Ready?
Yes.
Okay. So it is interoception. Interoception occurs when a segment of bowel telescopes into an adjacent segment, resulting in colicky abdominal pain, nausea, vomiting, and potential bloody mucus stools. Classically present in an infant and young child with recurrent episodes of severe abdominal pain, often punctuated by asymptomatic periods. Anticonception typically occurs due to the presence of pathologic lead point, often like lymphoid hyperplasia, lymphadenopathy, macrodiverticular stricture, or malignancy, which acts to draw one segment of bowel into an adjacent segment during peristalsis. If the intussusception self-resolves, there may be no symptoms. If it does not resolve, traction of mesenteric vessels can result in hypoperfusion of the segment with resultant inflammation, hemorrhage, obstruction, and pain. It may be detected on physical exam as an elongated mass, often in the right upper quadrant. Diagnosis consists of clinical history, physical exam, and is supported by imaging. Ultrasound evaluation is preferred in young children and will show telescoping interposed bowel segment in longitudinal orientation or targetoid appearance in transverse orientation. A contrast enema can also demonstrate intussusception with appearance of a mass prolapsing into the of a lumen of and an inability of the contrast to reach the proximal bowel. Treatment of ileocolic intussusception requires the administration of contrast enema, which reduces the intussusception. Contrast enema is both diagnostic and therapeutic in this setting. Surgery may be required in cases where there is repetitive failure of the enema to reduce intussusception, or if the patient presents with symptoms concerning with bowel necrosis or perforation. It is not my rotation. Volvulus occurs secondary to incomplete rotation of the bowel during embryonic development. This places the newborn at risk of midgut volvulus, which present with bilious vomiting, abdominal distension, and pain. In severe cases, presentation may also include intestinal necrosis, hematochezia, perforation, and peritonitis. Okay,
Okay.
next.
A previously held, sorry, uh, a previously healthy 13-year-old boy is brought to the physician for weak history of intermittent left groin pain associated with a limb. He has not had fever. He is not in acute distress. He is at 50 percentile for height, 97 percentile for weight, above the 97 percentile BMI. His temperature is 98, pulse is 90 per minute, respiration 20 per minute, blood pressure 116 by 75 on examination. Internal rotation and abduction of the left hip are limited. Internal rotation and abduction of the left hip are rotated. Internal and external rotation to 75 degrees produce pain. The left hip rotates on passive flexion. Externally rotates on passive flexion. Examination of the right hip and both knees show no abnormalities. Anteroposterior and cross-table lateral X-ray of the left hip show irregular widening of the epiphyseal plate of the left femur and mild osteopenia of the left femoral neck and head. In addition to analgesic therapy, discussion of the weight loss, which of the following is the most appropriate next step?
Oh, let me see how. Ready?
Wait 1 second. Okay.
Okay, so it's internal fixation. Scurvy. It most commonly occurs in overweight children between like 10 to 15. It results in displacement of the femoral epiphysis relative to the femoral epiphysis relative to femoral neck, secondary to anterior superior movement of the metaphysis because of Salter Harris type 1 fracture of the growth plate. Scurvy typically presents with a painful limb and, if severe, may result in restricted range of motion of the hip joint, limited abduction, internal rotation of the hip, and in inability to bear weight on the affected lower extremity. Diagnosis require evaluation of both hips in frontal and frog leg views for comparison. If untreated, in complications include avascular necrosis of the femoral head, limited range of motion, and gait impairment and premature osteoarthritis. To prevent this complication, treatment requires surgical fixation of the femoral epiphysis. Physical therapy will be appropriate in the setting of muscle or ligament strain or sprain. This patient does not present following an injury, and sprains of hip joint ligament are less common. Okay, so scurvy is so for the babies is the how is it called? The one where the dislocation is called the my lord.
Which one?
There's one for the dislocation in the babies, the one where there is the click sound for the hip.
Developmental dysplasia of the hip. DDA.
Especially that one is for babies, so less than 5. Then there is one from 5 to 10. It's called what is it called? 5 to 10 is ah there is one from 5 to 10. Is the is that the Osgood?
Osgood-Schlatter. Osgood-Schlatter syndrome. I
No,
don't
it's not.
think so. It is in the hip.
No, there's another one in the hip. That's for 5 to 10, and then there is scurvy. That's from 10 to 15. What's the 5 to 10? Oh God. There is another one in the hip. What is it called?
Is
No,
it sorry.
the osteonecrosis one.
Os
The osteonecrosis for
the
the baby.
osteonecrosis of
Uh,
the femoral head.
yeah, what
Like
is it called?
like
The name is not coming, but you know what I mean. You
leg
know the one.
calf part disease.
Metaspastic, whatever this is. Okay, so that's kind of hard to remember. For the babies, is the development. So it's D. It goes in alphabet order. So D, L, S. Wait, does S goes before L? Yeah, L. Yeah. Yeah. So the D for the babies before 5 years old. Then the L is for the 5 to 10, and then the S is for 10 to 15. Okay, got it. Next.
So DLS method. DLS.
Oh, that's a good. Yeah, I didn't.
DLS. Have you do you know about cricket?
Click no. You are like the second person that asked me that. My was it my tutor that asked me that too? I don't know. Or was it you? I think you are the one that told me about the cricket before. About
Yes.
the guy that in your
Cri
country that had
Cricket is a very popular sports in our country,
yes it
in
was
your
you.
tutor's country.
You. Yeah,
Okay.
that was you that told me. Yeah.
So in cricket, there is one method called DLS. Okay.
Hmm.
Don't try to remember on that way. Okay.
Okay.
Okay. Next. Okay. Mm, a 9-month-old boy is brought to the office for a well child examination. His mother says he is happy baby. He likes to lie on the floor and can roll from his stomach to his back. He has been trying to roll from his back to stomach over the past 2 weeks. He can sit with support. His appetite is good. He likes to feed himself. He likes to feed himself crackers and cereal from the high chair table. He jabbers, imitates sounds, and says Dada Mama to everyone and everything. Immunizations are up to date. He is at 75th percentile for length, 50 percentile for weight. Examination shows no. Which of the following is the most accurate assessment of this patient's development?
Ready?
Yes.
So it is E. Yep, I guess. Developmental milestones refer to actions that most infants or children can perform at any given age. At a given age. By age 9 months, infants are typically are able to initiate and maintain sitting position without support. The patient in this example is unable to sit without support. Wait, I thought he was able to sit. Okay, I thought he said he was able to sit. He's trying to roll, blah, blah, blah. He can sit without, oh, he can sit with support. Okay, never mind. Indicating that his gross motor developmental development is delayed. In the fine motor category, infants are expected to be able to rake food towards themselves and move objects between hands. In the language category, most children can make various sounds, including mama, dada. In the social category, most patients fear strangers, display affect, and look when the name is called. Screening for developmental delay alert physicians to the potential need for further evaluation and or early referral to developmental specialists. Early intervention has been demonstrated to improve outcomes. I can never remember those developmental things. Like I just gave since medicals, I just gave up because I was like, there is no way I can remember what they're supposed to
Yes,
do. I can't,
that's very tough.
it's just
It
impossible.
should it is the thing for the pediatric neurologist or pediatric person.
So my tutor was he emphasized, he was like, there are mnemonics, and he would show me this mnemonic and this, and he was like, you need to remember. I'm like,
In
I
the
can't. I
e-world, there are plenty of them. Like, I try to remember, but
Yeah. I was like, this is impossible. He was like, no, but it's important. You must remember. But it's probably like, I don't know, one
oh
question in
yes,
the,
one question may come.
in the whole exam. I'm like, I feel like, or maybe two in the whole exam. I feel like, yeah, okay, fine.
Like
I don't like,
if you suppose you know everything, you remember everything. The option is age. If you start excluding, it will take time.
yeah, that's like, I don't know. I'd rather miss those 2 points and get all the other points because I'm like, yeah, there is no way. This is just going
Yes,
to give me.
yes, we need to reduce our temptation.
Yeah, because this is just going to waste time. You're not even sure that what you're picking is,
Is it correct? Yes, true.
yeah. And then you wasted time for just that one question, and it's
And then at the very last period, we will miss the very simple one.
yeah. And then I
Most
think
of the
divine
blocks
has
I found it like this way. Like
a,
the last questions are very easy, but we
yep,
have not enough time to read it out.
yeah. Like divine in one of his videos, he was like, those experimental questions, don't waste your time. Just leave them till the end. Um, answer all the questions, leave them to the end. And if you cannot get that to that at the end, it's fine. Just don't stress yourself on that. Don't, yeah. Or just once you see that okay, you can, there is no way you can read the experimental question, you have like less than a minute left, just pick something in the experiment, just pick C, and then move on. But don't try to answer them before you have finished the whole block. It's like it's not worth it. You might as well just lose those points from the experimental questions. And he has a video where he just gives like tips on like how to take like exam taking strategies and stuff like that. And I think one of them was this was the one with the developmental master. He was like, listen, this those questions either you know it or you don't know it. Don't waste your time. If you know you have not memorized and you don't know it, just pick something and move on. Because there is no thinking there and trying to be logical and think now. Just pick something and move on. Yeah.
True.
Yeah. Next.
Okay. A previously healthy 15-year-old girl is brought to the physician because of severe cramps during menses. Since menarche at 6 months of age, mens occur at regular 28 days interval. Treatment with over-the-counter analgesic and NSAIDs have has not relieved the pain. Examination, including pelvic examination, shows no abnormality. Which of the following is the most appropriate next step?
Ready?
Wait one sec.
Mhm.
Okay.
Okay, so is OCP's primary dysmenorrhea is defined as menstrual pain that accompanies each menstrual cycle but is not associated with underlying pathology. To diagnose primary dysmenorrhea, causes of secondary dysmenorrhea must be ruled out. These may include endometriosis, fibroids, adenomyosis, adhesions, pelvic inflammatory disease, adenomyosis. Many of these can be reasonably assessed on pelvic exam, which in this case did not show any abnormalities. Primary dysmenorrhea typically presents with pain in the lower abdomen and pelvis, which may radiate to the lower back or thighs. It's often accompanied by nausea, diarrhea, headaches, and flushing. Symptoms typically begin in adolescence. It can be attributed to uterine vasoconstriction in response to excess prostaglandin. Thus, treatment targets this pathway. Medications such as NSAID and topical heat therapy. Combined OCPs or progestin IUD may also be utilized to regulate the symptom if persisted. It's not E. Laparoscopy can be used to aid in diagnosis of multiple intra-abdominal pathology. Common region for laparoscopy of endometriosis, which presents with chronic dysmenorrhea, dyspareunia, dyschezia, and infertility. This patient has none of the symptoms or other intra-abdominal signs or symptoms to justify the need for invasive procedure like laparoscopy. Okay, next.
A previously healthy a previously healthy 10-year-old boy has a 10-day history of progressive cough, low-grade fever, slightly slight dyspnea on exertion. Examination showed diffuse crackles bilaterally in X-ray of the chest show diffuse bilateral infiltrate. Which of the following is the most likely diagnosis?
Hmm. Step pneumo. Step pneumo is no. Hmm.
In strep pneumo, should not we need high grade fever?
First step pneumo was the lobar, not is lobar, is not
Yes.
diffuse. Mhm. Mm,
O- Okay.
Ready?
Yes.
So it's Mycoplasma pneumo. The diagnosis is most likely Mycoplasma pneumonia. Mycoplasma is a pleomorphic organism lacking cell wall that is typically associated with causing atypical pneumonia in young patients. It is transmitted by respiratory droplets. The most common symptoms include mild fever, headache, and non-productive cough. Physical exam findings may include bilateral crackles and or wheezing, um, and a vesicular rash. Chest X-ray characteristically has an appearance that is more severe than the patient clinical presentation, with patchy or diffuse bilateral interstitial infected. Mycospasma is a fastidious organism and can be grown on eaten agar, though this can take weeks. It also may not appear on gram stain because it lacks cell wall. The diagnosis is usually based on clinical presentation. Lab studies that support the diagnosis include a high titer of serum cum agglutinins, IgM antibodies, high titer of cold agglutinase, IgM antibodies. Treatment is with macrolide, antibiotic, doxycycline, and fluoroquinolones. Other atypical pneumonia that may present similarly include respiratory virus, chlamydophila pneumonia, and Legionella infections. Next.
Next. A 3.2 kg male newborn is delivered at 38 weeks of gestation. Pregnancy, labor, and delivery were uncomplicated. Outcome score was 8 and 9 in 1 to 5 minutes, 8 and 9 in 1 to 5 minutes repeatedly. Examination shows no abnormality except for bilateral flank tenderness. Hematocrit is 50%. Hematocrit is 50%. Serum urea nitrogen is 8 milligram per deciliter, creatinine zero point 0.9, pH 6, specific gravity 1.009, blood is moderate, protein is stress. Ultrasonography show bilateral enlargement of the kidney with mixed echogenicity. Which of the following is the most likely diagnosis?
Mm. Ready?
Wait.
Mhm.
Bilateral. Okay.
So it's polycystic kidney disease. What is it? Polycystic kidney disease can be either autosomal recessive or autosomal recessive of dominant autosomal dominant polycystic kidney disease. Autosomal recessive polycystic kidney disease results from a mutation in PKHD1 and is a form of infantile cystic kidney disease that manifests with the development of numerous small kidney cysts that replace the normal kidney parenchyma, resulting in end-stage kidney disease, which typically requires dialysis and or transplant at young patients. It is associated with hepatic fibrosis and Caroli disease. Aneurysmal vascular disease and hepatic cysts are often present in autosomal dominant um, polycystic kidney disease. It has variable age of presentation during fetal life or childhood, but can be potential cause of oligoamtranius or pulmonary hypoplasia if it develops in utero. How old is a male newborn? Okay, it's not neuroblastoma is a malignancy of neuroendocrine cells of the sympathetic nervous system that commonly affects adrenal glands. It may be differentiated from other common abdominal malignancies of childhood by its tendency to cross the midline and have a nodular texture, along with its association with paraneoplastic of subcutaneous myoclonus syndrome and increased concentration of serum and urine catecholamines metabolites. It is not renal vein thrombosis Occur most commonly in patients who have underlying thrombophilic condition and can present with flank pain, hematuria, and kidney injury. It will not distort intrarenal architecture like that seen in polycystic kidney disease. Okay, next.
Okay. Next,
Mhm.
a 10-year-old boy is brought to the office. A 2-day history of redness and mild pain in the left eye. His febrile examination of the left eye shows mild erythematous conjunctiva. There is conjunctivality and tenderness, a 3 mm nodule at the lower lower lateral lid margin. Examination of the right eye shows no abnormality. Which of the following is the most appropriate treatment? The lateral margin.
Mm,
Is it style?
Guess. Ready?
Yes.
So swarm compresses. A hordeolum or stite is a common acute infection of the oil glands of the eyelid. Patients present with focal, well-defined subcutaneous nodule at the eyelid margin with associated skin redness. A blocked glandular orifice may be visible as a focal white point at the eyelid margin with associated discharge, which may cause ocular surface irritation and conjunctival injection and chemosis. Or Hodele may progress to preseptal cellulitis, which is characterized by diffuse redness, warm, and edema of the preseptal soft tissues. The underlying cause is obstruction of the oil gland orifice with subsequent accumulation of sebaceous material and overgrowth of the skin flora, most commonly with staph species. The meibomian glands or the glands of Zeiss and Moore may be affected. Initial treatment is with warm compress and gentle massage of the lesion, which help to dissolve insipated glandular material and promote drainage of the gland. Topical antibiotic ointment is helpful, although systemic antibiotics are not usually necessary. Incision or drainage may be considered for ordeola that do not improve within several weeks. Ordeolum should be distinguished from chalazion, which is a sterile, non-infectious chronic granulomatous inflammation of obstructed meibomian gland material on the eyelid margin. Okay, it is not the topical tetrahydrozoline is an alpha 2 adrenergic agonist that is available as an over-the-counter eye drop for reducing conjunctival injection. While it may improve the cosmetic appearance of the eye, it does not address the underlying cause of ordeal. It may increase ocular surface irritation. Okay.
Okay.
Mhm.
Okay. We can stop here and do some bias.
Okay.
So
Well,
today's
go ahead.
topic.
We already did clinical trials. I think we did that. I forgot. Let me see.
So now statistical distribution.
Did we do clinical trials? I don't think so.
Okay, then we do clinical trials.
I think we did confounding last time. Let
Have
me
we
look at
done it?
the confounding. I think
I
that we
think
did
that this question is
alcohol consumption
familiar.
in, yeah, we did confounding. Yeah. So it's clinical trials.
Okay, clinical trials.
Mm-hmm.
A clinical study. A clinical study is conducted to assess the role of the non-specific beta blocker in secondary prevention of varicose bleeding patients with liver cirrhosis. The first episode of varicose bleeding were treated with propranolol. The drug assignment propranolol versus placebo is performed randomly. After patients have agreed to participate in the study, a computer assigns random number to each patient, which places him or her in one to two groups. The drug assignment strategy is most helpful in controlling which of the following. Okay,
Mm, between selective survival and confounding. Okay, never mind. Okay, keep on.
a clinical trial is designed to evaluate the effect of a beta blocker. Uh, a clinical trial is designed to evaluate the effect of a beta blocker on the survival of a patient with class 4 heart failure. The beta blocker or the placebo therapy is given to the patient along with standard therapy for heart failure. Neither of the patient nor the clinicians are aware of the drug, beta blocker or placebo that the patient is taking. The later study design feature is used to prevent which of the following.
Next.
A large-scale, double-blinded, randomized clinical trial. A large-scale, double-blind, randomized clinical trial is conducted to assess the effect of a new aldosterone antagonist on the mortality and the morbidity of the congestive heart failure class 3 or 4. 2,000 patients are enrolled, 1,200 are assigned to the drug, and 800 are assigned to the placebo. According to the study results, patients treated with new drug has improved survival relative risk 0.85, p-value 0.02, decreased risk of hospitalization 0.65, p-value less than 0.01. The investigator also report that 10% of the placebo group and 14% of the treatment group discontinued therapy. That an additional 6% of the patients in the placebo group were prescribed a different aldosterone antagonist. It is described in statistical method that the analysis was performed using the intention to treat approach. Which of the following is the best statement concerning the benefits of intention to treat?
Forgot what was intention to treat. You keep the ones that I forgot. I completely forget. Next.
A large-scale clinical trial is conducted to evaluate on the effect of the beta blocker therapy on the survival of the patients with chronic heart failure. Class 4, the patients with severe heart failure are randomly assigned to carvedilol, a beta blocker, to the placebo. In their report of the study result, the investigator include a table with the baseline characteristics, age, race, prevalence, and hypertension as the patients. The treatment and the placebo groups, according to the table, both groups have similar distribution of these characteristics. The similar distribution of these characteristics are best reflects which of the following. Okay, can you read the explanation?
Okay, yeah, I'll read it. Randomized clinical trials are a type of interventional experimental study design and can provide the strongest evidence regarding an exposure disease relationship. Several important features of RCTs are discussed below. There are randomization, blinding, and intention to treat analysis. Randomization implies exposure assignment that is determined by chance. Neither the investigation nor the study subject has any control over placement. The goal of randomization is to create groups with similar distributions of known in question 4 and unknown variables. The only difference being the exposure assigned. Randomization therefore minimizes the effect of confounding. It also eliminates the possibility of susceptibility bias where the care provider systematically assigns patients to specific group based in part on the severity of the disease. So we have for question 4. That's why it's randomization because it's the way they assign the groups is randomly. Okay.
Okay,
Blinding refers to the study design technique where exposure status is kept hidden from the patient and or the investigator. Exposure. Okay. In single blinded studies, patients are not aware whether they are taking the drug or the placebo. This minimizes the placebo effect. The placebo effect can be especially significant in studies measuring subjective symptoms like frequency of headaches, overall well being. In double blind studies, both the patient and caregiver are unaware of the exposure status of the patient. Blinding the caregiver prevents conscious or unconscious misclassification of outcomes by the caregiver, a phenomenon called observer bias. Intention to treat is an important principle used in analysis of random RCTs. Intention to treat means that the patient's treatment status at the point of randomization is analyzed. If a patient who is assigned to the placebo group begins taking the medication assigned to the treatment group sometime after the study, or if a patient in the treatment group stops taking the prescribed medication, the data from these patients is still analyzed along with the original group. Okay. The value in the intention to treat approach is that it preserves the benefits of randomization and prevents bias due to selective noncompliance. Investigators may alternatively use the as treated rule, which is the opposite of intention to treat. Example, if a patient switches therapy, they are counted as member of the new group during analysis. So that answers the question number the number 3. That's why it preserves the advantage of randomization. They didn't really answer question number 1, but yeah, it's confounding.
okay,
Got it?
yes.
Yeah. Okay, perfect. Now will see you tomorrow.
Okay.